right, so thank you for joining this Q&A on program certification. I'd love to have our panelists take a minute to introduce themselves and their role in LBC and the expertise that they're bringing to this discussion. Whichever one of you would like to go first.
Right. I can go. I am Kim Vay. I am based out of Atlanta. I'm the program director, the director of the DBT program at Peachtree Comprehensive Health, the big private practice in Buckhead in Georgia. We have a cognitive center. We have a psychiatric. We have 9, 7, 8 psychiatrists, I think. And then we have a comprehensive DBT program that got certified in September of last year. Prior to coming here, I worked most of my clinical in Hillside Hospital in a residential facility, which I led them through certification as well prior to leaving there. And so they got certified in 2017 maybe. And then I came here and we got certified last year. So I work with adolescents and adults and do mostly trauma. A lot of trauma within the DBT program, and I'm the president of the Linehan Board.
Right. So for me, I'm Essie Larson. I'm a psychologist in New Jersey. I am the director of the adult DBT services at Trinitas Regional Medical Center, which is an inner city hospital in New Jersey. So we're the only program in New Jersey that takes Medicaid, Medicare insurance and has charity care. For DBT, we also have an adolescent program, and we also have an adolescent Spanish program. So we got certified in December of 2021. I'm also the co-chair of the legislative work group for DBT-LBC and on a couple of other committees as well. So, and program certification is something I'm very, very passionate about. So I was very happy to be able to be here and be part of this town hall.
Thank you guys. I appreciate you guys coming and donating your time to the discussion. If anyone has any questions for the panelists, you can just put them in the chat or email me if you'd like them to be anonymous. While we're waiting, we didn't have any pre-submitted questions from before the meeting. So while we're waiting, I can just ask you some questions myself. But if you guys have some specific questions that you'd like, we would prefer to answer whatever you guys would like to know in this meeting. So I'd like to give a chance for you guys to talk about difficulties affording program certification. I know it's a very costly endeavor, and I know that we have some stuff that can help with that. So can you guys speak a little bit to the scholarships we have for program certification?
Do you want to talk about that?
Yeah, so we were lucky enough, we applied and got the program certification scholarship because we work in it with an underserved population. And so that paid for, it's almost half, right? Is that what it is? Because it pays for the site review.
Pays for
portion.
it pays for the $2,000 site.
Yeah. And so we would not have been able to do this unless we had qualified for that. And so we were so thankful, and the process was very straightforward, and they got back to us pretty quickly with the results. And I highly encourage any program out there that meets the criteria to apply for it, because the funding is there. And we want, especially, programs that are dedicated to increasing access, to be able to get certified, and that can help you do it completely.
Yeah. Awesome. Kim, do you have anything else you'd like to add about that?
If there's any questions on the qualifications, you could just submit and see, or you could always email the contact us DBT-LBC and ask any clarifying questions if there are any questions around qualifications, but I wouldn't let that initially stop you from applying.
Yeah, I posted the link to the qualifications and the form that you can download. It's a pretty short form. It's not like that extensive, so it won't take that long. to apply for the scholarship in the chat. So hopefully that's helpful. Okay. So I see that there's not any questions yet. Again, if you do, please let us know. I wondered if, like, in lieu of questions, we could just maybe start by talking about the components of applying to the program certificate, to get program certification. Sorry for my misspeak. And just talking about going through the program manual and how to start the application, and that might kind of get us started in the discussion.
So the first part of the program is, so if you can put, Jessica, can you put the PFS in the chat?
Yeah.
So we are in the process of doing a PFS version 2. However, that's not published yet. So we're still using this program fidelity scale. So what I did with both the programs that I was a part of is I gave this to all the team members. And this is just like a personal thing that I did. So this isn't like part of the process, but I gave it to the team members and had everybody fill it out and just bring it back to team or to like one of our meetings to see like where do we all fall within the sort of those categories that are in the fidelity checklist. And that yeah, so Jessica's put it in the chat, and that can help just to see where your program's at. If it is, where it's from 4 and 5 is what is required, and sometimes 4 is, it just depends on the element, but that can really help you first just determine like how far are we from this process, or like we're pretty close. What you may find, at least this is what I found, was that we were really close. We were very, very close. We just didn't have everything packaged, like in terms of the program manual, right? We had all the components. We were doing all the things. They just weren't necessarily like packaged into a manual format. And so that can be just the first part of it's a pretty cool team experience too. Whether you decide to pursue certification or not, it helps to just see from the research, because everything throughout the program certification is based off the research. So nothing is arbitrary, or nothing is, oh, we think this would be a good idea to put here, or we think that this criteria should go here. It's all based off of RCTs and where the research is. And so whether you decide to pursue certification or not, that can be a really cool just sort of team exercise to see where everybody thinks everybody's at, and see, well, I didn't think we had a gap there, but where do you see this gap at? I don't know. It can be just a really neat activity to do with the team too. So that would be what I would recommend as like the very first step. And then you have to have a certified clinician at your practice, an individual DBT-LBC certified clinician to apply for certification. So that person functions as the team lead in the application. And so then the next process is opening up an application, which has more than just demographics. It really is it's an overview of your entire program. I don't know if it would be helpful to go through some of those components.
Yeah, maybe we can.
Okay.
I love the idea of doing it as a team exercise. That's a really cool, instead of just like the team lead taking it on, like involving the team in that discussion and getting feedback and kind of like seeing what's being left out and what are we missing from everybody's perspective. I think that's a really cool way to frame that.
And I think that, depending on where your practice is, like, because we were within a hospital setting, a lot of the things that were necessary for the program manual, we already had written up because it's a required part. Like, we had to write up all of this stuff as policies and procedures for our hospital. So we were able to just transfer it into the program manual. But I know for a lot of private practice models, you may not have a program manual. And so really doing that first, like Kim was talking about, is essential, because I think it becomes very difficult if you put in the application and then you have to create the program manual from scratch. You'll find it incredibly overwhelming in that process. So really doing everything Kim talked about in setting it up ahead of time and assessing for how close you are is probably the best method.
Because both the program manual and there is on the website, there's in the tab that says program manual guidelines, I know our website can be confusing, but we tried to just lay out the guidelines and on that one page. And if you look at again, whether you end up, hopefully you do, but whether you end up pursuing or not, the program manual is a really good manual to have for like new hires or for anybody who needs to just reference something. And it has just all of the components. And you'll probably find as you look through the guidelines that need to be in there, those, if you're running a DBT practice already, you're doing all of that and you have all of that. Like, so when I first looked at it, I was like, how are we going to then, but when I actually sat down and looked, I was like, we have all this. We just have to like get it and put it,
You have
package
to
it,
put the
right? Like, so it's about,
documentation.
it's about like packaging. And I know there's a question in there about templates. There's no
Yeah,
required.
let me read that question really quick so
Okay.
everybody has it. We had a question submitted about how do you get started with a program manual? Are there any templates? So that's what Kim's referencing.
So there aren't templates. It's more of like just hitting the points that we're looking for because it's a comprehensive, essentially all of the points in the manual are a comprehensive DBT program.
And I would say we've discussed, I think, sometimes about the idea of having templates eventually as a goal. I know that you can, of course, ask programs that are already certified if they're willing to share their program manual with you. I know I've shared mine with several because I think why start from scratch if you don't need to? So definitely that would be something that you could do as opposed to starting on your own.
Yeah. Okay, let's respond to some of these other questions. We might circle back to the specifics of the manual if we have time. Someone wrote in saying, I understand that consistent with evidence-based and adherent DBT programs should be contracting for 12 months with incoming clients. I'll summarize the last chunk saying, I understand that that's a case-by-case thing. Is there like a threshold for we have too many people in our caseload that's 6 months versus 12 months?
What I would say, because I've actually had these discussions a couple times, so it also depends on whether you're talking about adolescents or adults, because for adolescents, it's 6 months. So for adults, the expectation from the conversations I've had is that it's a year, and there's also the possibility of, we know that sometimes programs have 6 months. They need to be very, very clear with the clients at the beginning that the RCTs show that people need to go through the skills twice to be getting the treatment the way it was researched for adults. And so making it clear to people, if they choose not to have people go through it twice, they have to let the stakeholders know that that is not what the RCTs show. And so I don't know what you think, Kim, but in terms of the threshold, I don't think there's a specific threshold, but they do ask that question of like, how many people actually did the 2 cycles as opposed to doing 6 months and then leaving.
Yeah, and I think, I mean, it is a hard, it's not like a hard number or percentage, because again, it's looking at, you know, we have clients who come from a residential DBT program. So they may not, you know, like our treatment agreement is 12 months, but we're still assessing, right? And so we're not necessarily looking at any threshold or numbers. It's just, or do the clients know that the expectation is 12 months? And then whether, you know, a lot can happen in those 12 months, right? Like, and so it's not, because DBT is not contractual. So it's more agreement and, you know, them just being informed of the rationale behind the 12 months, but we're not coming in, we wouldn't necessarily come in and say, oh, you know, you have X amount of people that didn't do it 12 months, so you don't meet that threshold. That isn't something that we're looking at, because a lot can happen. And
Mhm.
I mean, there can be effective treatment, and yeah, I mean, like, life happens sometimes with clients. And so there isn't a threshold. It's more of an expectation that the client is informed from the beginning. And the
Mhm.
treatment agreements are, and I'm happy to share a treatment agreement if anybody doesn't have one or would like to like an example. I'm happy to share a treatment agreement. We have separate ones for adolescents and adults that have different 6 months versus a year. And I think the concept there too is it's adopt it first before you adapt it.
Mhm.
Right. And so everybody coming in, we're adopting the 12 months. And then if there is an adaptation, there's a rationale behind it, and it's not from the beginning. And so I think that the informing them from the beginning of the rationale helps. Also, in my opinion, that has helped with commitment, because then it doesn't just feel like we're dragging it on, and the time frame helps me just clinically stay not dragging it on. It'd be very easy to just drag.
So there were some people who were interested in your treatment agreement. Is that something that you could share in the chat now, or do you want me to collect emails for you to follow up? Like, how would you like to share that?
So I don't know how to share in a chat a document.
Okay.
I'll share it with Jess. I'll share it. Or if you want to however you want to do it, I'm happy to share. So however I can get it to you, I'll get it to you.
Yeah, sure. You could if people want to put their emails in the chat for any follow-up documents from this, or you could email the email address that I put at the beginning, which I'll put again, socials@dbt-lbc.org. And I'm happy to, nope, that's not that was a link. Sorry, I pushed enter really quick. And I will follow up with anybody afterwards with anything that we've agreed to send out. So just
I'll send mine too, because we have ones for the initial 12 months and then for 6-month increments afterwards related to graduate group and stuff like that. So I can send those as well.
okay.
Okay.
Awesome. Okay, so the next question someone sent in was, if you have 5 skills groups, one each day of the week, are all 5 groups observed?
So they're not, the question is, are they all adult? Are some of them adult and some of them adolescent? Because that's for all adults, then only one. Right, Kim? That's
If you have
usually what happens.
one, possibly two, just
Possibly
depending.
2 if it's 5. Yeah.
I don't know if we've ever had a program with 5 adults.
No, I don't think. Sometimes we have like 3 adult and 2 adolescents. So then 1 adolescent and 1 adult group would be reviewed.
Okay, cool. How are clients chosen for the interview process?
Clients and charts. So try to make this not confusing. Clients and charts are the only 2 things that are not random, right? Because there's the last thing we want to do is make anybody feel uncomfortable or interfere in any way with anything clinical, right? And so I understand that, like, there's a lot of reasons why maybe a client would not feel comfortable being interviewed, right? And so you choose the clients and you choose the charts that get reviewed during the clinician interview. They do not have to be the same client. They can be, but they don't have to be. And so those are the 2 things that are not random. And we just ask for a mix of clients. They can be from certified clinicians in the program. Obviously, we don't want all the clients chosen to be just from the certified clinicians, but they can be. It's just like a mix across the board. And we ask that they are either in DBT or they have not they've graduated less than 6 months ago. So they may be doing, stage 2 PE work or doing other stage 2 work. And so they may have, if they've graduated from skills group, but they just can't have graduated. We ask that they've been within 6 months of the program.
Mm-hmm. And just to kind of add to that, because seeing as our program we have stage 1, we have a grad group, and we even have a stage 3 group for people. DBT-LBC only looks at the stage 1 skills groups. So they're not going to observe a graduate group, and they're not going to talk to clients who are in a graduate group or a stage 3 group that are more than that 6 months out of stage 1. So they have to be clients who are also in the comprehensive DBT program, because we know some programs have comprehensive DBT clients and then have people who join their groups who may not be part of comprehensive DBT. Those clients would not be interviewed. It's only people who are in the comprehensive DBT program.
As a follow-up, how many clients are you interviewing or reviewing charts for in a site review?
It depends on the number of clinicians. Well, yeah, so the client interviews depend on the number of clinicians and how big your program is. Typically we try to interview 2 to 3 adolescents along with their families, along with their parents, and then 2 to 3 adults. And then around 50% of the clinician interviews, around 50% of the non-certified clinicians. If your program has all certified clinicians, then we may interview a certified clinician. And then the charts, we ask that the clinicians have 2 to 3 charts ready to look at during the interview. So since it's virtual now, you just share your screen. We don't collect any information. So even for the client interviews, you don't send us Zoom, you don't connect us with the clients, you don't send us any client information at all. You guys take care of all that and we just join.
You don't even send us the names.
Yeah.
Okay, let's ask another question. Is it okay if some clinicians on the team are not treating stage 1 or stage 2 DBT clients, but are treating stage 3 clients?
So, I mean, they have to be providing clinical services within DBT. I'm not sure if we've ever been in that situation that I've heard of, Kim, where there were people on the team that weren't treating any comprehensive DBT clients.
So if you have someone on, so we have a program where there's like a newer clinician that just joined that hasn't built up a DBT caseload. So that just wouldn't be a clinician that would be chosen for an interview. So if you have clinicians that aren't providing DBT, we have a clinician here, pretty much her main caseload is doing DBT couples and families. Mm-hmm. And so we wouldn't choose her, she wouldn't be chosen for an interview. And so you sort of say, like when we ask you for your list of clinicians, you may say next to them, like, not providing DBT individually or something, right? Like something that would flag that they wouldn't be a clinician that we would choose.
And I think also just following up with that, one of the questions that is kind of related to certification is whether or not there are people that are part of your consultation team who are not providing DBT services, like at all. I mean, because that could be, people could be doing skills groups, people could be, offering coaching, people could be seeing individual clients. If there are people who are not actually providing any services to DBT clients, then that might be something that would be questioned.
Okay, thank you. Let's see. Can you speak about some of the complexities with a program that a program might face due to the fact that they might have 2 teams in one practice? So they might have divided teams. She says at times we're one larger unit and at other times we're smaller units, depending on the activity. Like team is broken down into 2 teams, but the training is all one program just due to size. She's like, I'm not sure what I don't know to ask, but I'm sure that some things might be different.
I mean, I can speak to it because our program has 2 teams. We have one team for adult and one team for adolescent. So they visited both teams. I've also done a program review on a larger program that had 2 teams separate, all for adults, or that, no, it wasn't, they had adult and adolescent together on both teams and both teams were observed. So that's been my experience that it's not really a problem if they split it.
We just would if it's split, there needs to be a certified clinician on
both.
So the complexity with that, if you only have one certified team lead, is that they would sit on 2 teams.
I also think that just maybe making sure there's some consistency also across the teams, as opposed to people constantly switching, like going to this team on one day and this team on another day. That just could make things more complicated for the clinicians, feeling like everybody knows their cases and are getting consistent support.
I have a question that I think we've covered parts of, but I just want to ask it again in case there's like a nuance that you didn't say. Like in just all of what we've talked about, we've covered parts of this. Does it matter if you have clients who are not receiving comprehensive DBT in your program because it is not needed and they are in stage 3 and are not in skills group?
No,
We just wouldn't interview them.
we wouldn't interview them and they wouldn't be counted your numbers. So like we have in the program that I'm in, we have a mix, right? Like all of our, we are a comprehensive DBT program, but we have clinicians on our team that have, littles that see the little ones. And so there's like, we have more variety. I mean, I couldn't see 28 stage 1 DBT clients a week. I don't know if any of you can, but if you can, kudos to you. So it's just, it wouldn't go in your numbers, and it wouldn't, because on the application, it asks how many current DBT clients are in your program. And so those clients that aren't in DBT, that may be DBT informed or just getting support otherwise, would not just go in that number.
Okay. Is it possible to opt just to have an adult DBT program certified, even if you have an active adolescent program?
Yes, so we would just ask that there was clarification on any marketing materials or website of stating which program is certified.
Awesome.
Usually we could even have a blurb for you, but it's usually just saying that the ad, like worded so that it doesn't look completely like this program isn't valuable, right? Like because it's not certified, but just that it hasn't independently been reviewed, as opposed to it looking completely different. That would just have to be notified or identified that way.
Yeah. If sorry, this is a question aimed mostly towards Essie because they have a similar setting to you. She's interested in hearing your thoughts about how certification process might differ for like an adult PHP setting or a residential setting that exists in a wider system like your hospital setting. Either of you can speak to it, but I know that Essie, you're also in a hospital.
Yes. So for me, I think because ours is outpatient, so it's not a PHP or a higher level of care. But I think that it's important to remember that you're not able to always follow DBT exactly the way the model says when your administrators are telling you other things. And so before you go for program certification, I think there has to be some very clear understanding of how it still comes down to the team as who makes the clinical decisions. And so I know for us, before we went for program certification, we had a big thing related to medication providers, and we had to create a specific form that needed to be given. Like DBT-LBC didn't ask for this, but I was concerned this would come up, that really laid out like, okay, med providers, this is the stuff we'll tell you, and this is the stuff we won't. And kind of, you need to be okay with that. And then we were able to connect with the chair of psychiatry, and he was kind of our go-between, that if there was anything we had a question about, he was knowledgeable about DBT. So we had in there, we would go to him, and then he would make the decision of whether it was something that had to go kind of med providers or something like that. So to me, that's the biggest complexity. And then I think for us also just the idea of risk and how risk is managed based on the larger organization. And that really led us to make our notes very different than probably a lot of other practices that put a lot of information, whereas we just refer to target 1, target 2, target 3 behavior in all our notes and don't give any specifics, because the other people don't know what target 1, target 2, target 3 means. And so then we don't have to worry when anybody goes in to look at it. So those are some of the things, but I'm more than happy to talk about that at like another time if you want to reach out and talk about all the complexities in getting this program where it's at after 17 years.
Essie, if you want people to follow up with you, it might be helpful to if you shared like an email, your preferred email address.
Absolutely. Let me do that.
Not saying that you
No, that's fine. I love talking about this stuff. So
no pressure. Okay, let me ask the next question. If a team does RO or contextual DBT as well, do you take that into account with certification? My understanding is that you only certify the comprehensive standard DBT program.
That's correct. So we would also we're not certifying DBT for child or any adaptation, any other treatment related to DBT that it doesn't have a certification attached to it. Right now, like DBT SUD, none of those programs we would observe, and they're not problematic, right? Like it's not going to come up as anything problematic, but they would not be part of the site visit. They would not be part of your like it may be part of if there's ancillary services from SUD or anything like that. But I think maybe in our program manual, we might have something in there about DBTC. But I don't think I put any, at the time we went through it, we had RO. I'm not doing RO right now, but I don't think I added RO at all in there. But you could if you wanted to, but we're not looking at that at all. And but it also is not at all problematic.
I wish I'd seen this question when we were discussing the non-comprehensive DBT part. Can those clients that are not comprehensive DBT still be discussed on our comprehensive DBT consultation team?
So the way we do that here is we rate sort of how important or how high risk what we need is. If it's something that like I have a session this afternoon, then it's going to be rated a little bit higher than, and so the non-DBT clients, their rating gets lower or they get talked about at the end of team. They just don't take up team from comprehensive clients, but they can still be discussed.
Yeah, same thing here. I would say we consider within our hospital our graduate clients to still be part of our definition of comprehensive, so they get discussed more in team. But the stage 3 clients, because they're not allowed to have an individual therapist as on our team, it rarely gets discussed, because it would only be if something came up in group that is interfering with the group leader's ability to be the best DBT therapist that they could be, then that would get brought up.
So I'll just say real quick while we're on consultation team, that consultation team is probably one of the main areas that we provide feedback on. And so when you go through the site visit, you will get suggestions, these are suggestions that we have noticed. We think that this could be helpful in strengthening your program. We've noticed this, whatever suggestions we have, and they are sort of like take it or leave it. They're obviously, we found a lot of programs that implement them. They find it is really helpful, but they're not required. And then there's recommendations. That the recommendations are until you correct this, and we usually give a time frame and there's details around that, then we can't move forward. So a lot of the team stuff, a lot of consult team has a lot of suggestions, because what we find is a lot of teams are very, like when I joined the team here, it was very heavy on validation and not on emotion. Like really, it's just trying to make everybody feel better instead of like seeing what needs to change or what the clinician can do differently. Or if they're coming, or if we have seen on teams where there's members that may have come from a higher level of care or come from a facility, the team looks more like treatment team. And so there's more case consultation versus treatment for the therapist. And so a lot of feedback that we end up giving is that team was a lot about the client and a lot about a case conceptualization, or like it's essentially like a treatment team in a facility is what sometimes it feels like. So I think that's Jennifer Sayer's book is like fabulous to have the team read and like sort of just go back to the basics on that, because I think there's not a lot of training on consultation teams, I guess, because that's just an area that it's so easy to drift into case conceptualization or consultation on cases. So that's, I think, probably one of the main areas that we have feedback on.
I know I'm not a panelist, but just to add a tidbit
Add.
here of like
You want me to pin you?
no, I
I'll
mean,
mess up the whole screen if I try to pin you.
you're welcome to, but I don't need that. I just wanted to say, like, I know that this process is so vulnerable and it feels like your whole like work expertise is on question. And I was a part of Jennifer Sayer's team when she got certified. So she wrote the book on teams, and the bulk of our feedback was on our consultation team. So like like she would be considered the expert, and we got a lot of feedback on our team about being more behaviorally specific. So everyone gets feedback, and it's just an opportunity to grow. So I don't know. I just thought that a little bit of like, it's okay to get this kind of feedback might decrease some intense. I don't know. It's hard to put yourself out there for these kinds of things. So,
well, the other thing I would tell you all, and for you to share with your team, is that this is not an audit.
Mm-hmm.
Like the whole process is not a process of an audit. I just was communicating with the team this week, and I shared for the team lead to share with the team that this is like, it's a dual purpose, right? Like, yeah, we're coming in to give feedback to see if the treatment is in line, but it's also a time for the team to shine and brag and boast on the work that you're doing, right? And so it isn't just, we're not coming in just looking for the flaws, which is what makes, I think, a program reviewer so amazing, is because we learn from the programs, because it's like we learn what they're doing that would work in a program that we're at. And so it's not, I think the anxiety comes from, at least the two programs that I went through certification with, the anxiety comes from feeling like we're going to be audited. And my program here that I'm currently at did not pass the first time. It didn't, I don't want to say it didn't pass. It needed revisions before, so we had to wait 90 days to come back. And I'll tell you, it was like a game changer. And it was just a huge blind spot that sometimes you need an outside person to really, like, looking back, it's like, yeah, we probably knew it, right? But we didn't, I don't know, we didn't notice it. And so it has been a game changer in the program. So, and having to wait, depending on what it is, how structurally the change needs to be, depends on like the time frame. Because if it's something, we've had feedback with groups and it's like, we'll come back next week or in 2 weeks to review another group, or it may be like, we need to wait 60 days while you implement this and get it going. But it is a time for the team to also brag and shine. And it's a time for the clients we always leave time at the end of the interviews for the clients to share like quotes and different things, so that it's just for them to also feel proud of the program that they're a part of.
And I think also, we all agree in being team members to like the fallibility agreement. And that's so crucial. And this is the time for all of us to really live that fallibility agreement and recognize that most change comes from tension, not from things going smoothly. And if you go in with an open mind and like, I'm going to hear feedback, and there's going to be some suggestions that come up that, maybe it's that they don't understand how the whole system works, and so the suggestions don't fit with what you're going to do, that's okay also. And then there's going to be things that come out of it that you're like, oh my goodness, that's a game changer. And so the more openness there is, that, as Kim said, it's not about an audit. It's almost like getting a consultant to come in and help you improve your program.
It truly felt like that for us. Like, it felt like a supportive, like, we got feedback that helped us be better. And like, we want to be better. That doesn't mean that feedback is always fun, but like, we want to be doing the best we can, I think, as a whole. So,
and I don't know if everyone on the call now is certified or is in the process of individual certification. But program certification you are assigned after the application gets approved. So we approve the application first, and then you're assigned site reviewers. And those site reviewers are sort of alongside you along the way. And so if you've been through clinician certification, so I didn't pass the case conceptualization the first time, and I thought my world was over. But I didn't get it right. You just get a letter saying you didn't pass. It's like, what do I do with this information? But that's not how program certification is, because there's not as many like risks and jeopardy to the test and that type of thing that feedback comes with clinician. And so if something needs to change, like the feedback that our program received, we knew exactly where our deficit was. We knew exactly what needed to change, and we knew exactly how we needed to implement it. And so we weren't left guessing. It wasn't like you don't meet standards and now here's this broad area that you don't meet in and sort of figure it out. It was very clear that here are the areas that need improvement. This is what needs to be done. And we had support along the entire way. And you have the same people along the way too. So you're able to communicate with them as much as you need to get questions answered and support. So it's not a sort of a, behind the paywall type process.
Yeah. Okay, we have a couple more questions. Does a crisis plan need to be in place in pre-treatment if there are no target 1 behaviors?
My understanding is a crisis plan of some sort does need to be in place, but what that crisis plan looks like is going to be very different for somebody who doesn't have target 1 behaviors. That's my understanding, Kim, right?
Like emergency contact information, that type of, and usually if you're using an EMR, that is in there. But we've actually moved over to switching all of our crisis plans to the one that was just posted on the listserv.
Is that Shireen's? Yeah, that's the one we use too. It's awesome.
Yeah. But yeah, we don't have a template for crisis plan. And so, and we may interview, or you may pull up charts for 3 clients, and they may have 3 different looking, like their crisis plans may look all different, which I think would actually be effective as opposed to having the cookie cutter, right? Like sort of if you go to an inpatient and they send you home with the one that they send everybody home with. And so those type of forms we don't have. I can put my email in the chat. You can always email me for templated examples, but we don't have anything required. It's more of the function, right? Like we're looking at the function of the document.
Okay. Another question. Is it okay to have some clinicians on the team that have not had foundational trainings?
No, the majority of ours, because we have interns, we have a psychology internship. And so, they get my training at the beginning, over the first couple months, they get 40 hours of training, but they're already seeing clients by the time they come in. So I think it just depends what your program includes, because if part of what you're doing is training people, then they probably will not have had all of that training, and they'll be slowly kind of fit into different roles, responsibilities.
And part of the program manual and part of the application asks for your training, what the training looks like. I can look at the actual question.
What are your training procedures, or for something like that? Orienting and training new staff.
Yeah.
While you're looking, Kim, if that is all the questions that I've had submitted during this. If I missed yours, or if you still have some, we have about 10 minutes left.
It's a training plan for new DBT therapists is sort of what we ask for. And we're not actually, not looking for, there's nothing we're looking for. We're just looking to make sure that we've had programs that have said they don't get any training until the 6-month mark. Well, that is hard to, right? Like, I get that, like, the investment, there has to be some form of training if you're doing the treatment, right? And so again, we're not looking for, there's not anything like hidden within that question that we're like searching for. It's just more of like, what is the plan to train them? And I know even with consult team, I have found that, you know, when things get busy and a new member joins the team that may have DBT training already and they join team, that it actually makes a difference when we slip through and forget to orient them to team, right? Like, so it's just those type of things. And that's where the program manual is helpful to, even for a new member to look at and say, hey, what does the orientation look like for team, right? Like, and so, because I think we all go through the, you know, this is easy-ish for us, and some of the things that aren't, we just miss, right? Like, we're all fallible drift.
Yeah. Should we include trainees on the application?
So yeah, my understanding when we applied, and also a program that I met with, that yes, the trainees are on there. I think something that's interesting that happened for us from the time we applied to the time we had the site visit is the people changed. Yeah. So that was just something that I let them know, like, hey, so some of those original names are not the names of the people you're going to meet when you come here. And I've seen that happen in another couple places also.
And your numbers have to add up. And so you'll put all of your team members in the application, their name, license, and if they're certified, although they will be listed in the certification. And then a question over here is how many individual DBT providers are there? And so those numbers have to add up. So if you have 10 members, but 8 individual, like, there's just question about those two numbers have to be the same. And then there's, you know, people leave and things change all the time. So every time you have a turnover, you don't have to worry about like updating your application. At the MOC, you can go in and update the new, unless there's any programmatic changes, like we know we, you know, no longer offer whatever, or we've added something major programmatically, but any anything else you don't have to worry about updating as they come, unless it is something that significantly impacts the delivery of the treatment.
And another interesting thing related to putting trainees on the application, a lot of our trainees got really anxious that they were going to be the ones who got interviewed. And we asked DBT-LBC, we were like, okay, like who are you going to interview these brand new folks? And they were like, no. Like, we want, like, you decide whether you feel as though they've been there long enough and know the treatment and have enough experience. So they're not going to meet with brand new people that came up, because then they're not going to get to see everything that is seen by people who've been there 6 months, 7 months, a year or longer.
And we're not trying to make this uncomfortable. I mean, it's already an uncomfortable, anxious process. And so when you send us the list of clinicians, there you can always state, right? Like, this clinician, like if they were to come to our program now, our one clinician, she does family and couples. It's not worth interviewing her for individual, right? And so you can state that. We're not trying to, now if everybody is stated don't interview them, then it's like, okay, well, you're the only one that wants to be interviewed. Like, there's maybe a question here, but for the most part, like, we're not trying to, you know, make it look like we're like digging for things, because if you got to this part, then it's a strong program. And we try, sometimes it's, you know, sometimes we notice things, like in my program, the thing that required us to have to make a change or to adjust is, but we try really hard to weed out and identify anything that would be a barrier to moving through before you get to the site visit phase. So if there's something that is very clear, like you don't offer any phone coaching, then you're not going to make it to the site visit phase, right? But there are things like that may all look good on paper, and it's not that you've fudged the paper, it's just that when you actually see it in practice, it looks a little different. And so that's what happened to our program. But for the most part, any of those bigger red flags, I guess you would say, we don't pass you on to the site visit, and we give you that feedback so that that can get corrected before you move on, so that you're set up as best as that we could see. And it's not like we're not just passing you on and then giving you all the feedback at the very end.
Yeah, and you might not even make it to the desktop review.
Yeah.
Before getting that feedback. It may just be right, you send in your application amount and a couple things are flagged and you're asked, like, what are you going to do about this, or like clarify it. And then until those are cleared, you won't be even moved on to pay like the desktop review. And that's with our program, we had one of those things that had to be clarified first before we moved forward, because nobody wants to put work in if it's already clear that you're not going to be successful.
And we try to so I review the applications with a few other people, and we try to set up a Zoom call or a phone call at a minimum to discuss anything, because of some of the questions that I have found that have come up on an application that have raised questions, when they're explained, they make total sense. Mm-hmm. Right? Like, you can only put so much on an application. And so we try to have a call to talk about what came up so that we can then, you have an opportunity to explain. And so then there are a lot of times where it's like, oh, okay, that makes sense. And that answered our question that we had. So we're not just going off of what we see and make an assumption. We will set up a call to discuss it, to see if there's we could possibly be reading it wrong, or what we're missing.
So I want to say, before we have one more question, and we have 3 minutes left, and I want to make sure that we're not running over and respecting your hours. We put up this like form that if you want to fill out to try to connect with other people going through program certification, you can give us your email addresses and I'll try to connect to you if you would like to have some buddies in the process. So you can fill that out, like, only if you want to. I'm just going to put you guys in an email so you guys can chat and introduce you to each other. The last question that you have 1 minute to answer, one of you, is there a typical length of time this whole process takes once we get started? It feels very big.
I would say that a big part of it is from the timing is from when you get the call that your application is accepted to when you're complete. Because sometimes there's part of the acceptance of the application that might take a little bit of time back and forth. I think if you have for us, because we had our program manual done, the process went really, really quickly. I think for us, from the point that we submitted our manual to the time we had our site review, was like 3 months, maybe 4 months. And it seems like is that average, Kim, in your experience?
Yeah, I think it depends too on the time of year, because hopefully when all of your programs get certified, you all will become program reviewers. Because it is a big undertaking for volunteers to do program reviews too, even though it is a super, like, I find it like clinically rewarding and helpful in my own practice. But it depends on the time of year, right? If you submit around October, it's hard to find, like, reviewers aren't really doing programs around the holiday. Like, so it really just depends, because sometimes there's finding having reviewers available, but we try to get through them as quickly as possible. The application is probably the quickest that gets approved to be able to start to get through the rest of it, but really depends on some factors that are more on our end in terms of like site reviewers. But I put my email in the chat. I am happy to share anything. I'm happy to set up a call with anybody on any program. We don't take insurance here. And so I know we've had a program that was more Medicaid insurance based, and I put them in touch with Essie. I think it was really helpful. And so some of that piece is unfamiliar to me. But I'm happy to answer any questions or share any information. This is I think we're
Yeah.
all in together, and this is not something that needs to, it is a big thing and it is anxiety provoking, but I think as much as we can support and provide and lessen some of that, we're happy to do.
Me too.
Yeah.
Feel free to reach out.
Thank you guys for coming. It helps us to know what things you need more help with and to just give more information in the future. So we'll do more of these coming up, and thank you guys. Have a nice
Thank you
day.
guys. Have a great weekend.
Bye.
Bye.